group. Just like to let's start with the admin. Hopefully everyone knows about use of mobile phones. If you want to speak, put your hand up. If you're on offline, if you want to use the hand icon to indicate that you'd like to speak. Recording of the public part of this meeting will be available on the council website within 24 hours of this meeting. I think that's about it. If we could start off by actually, we have apologies for absence first.
Councillor Nasser, Chair, who's been subbed by Councillor Raja.
Thank you. If we start off with, if we could go around and everyone can introduce themselves, starting on my left with 5.
Thank you, Chair. Councillor Clive Mead, Councillor for Sundon Park.
Thank you. Faith Haslam, Head of the Luton ICB Place Team.
Hello, Nikki Pillane, Chief Primary Care Officer and the Link Director for Luton.
Sandra Avis from Healthwatch Luton.
Stephanie Power from Healthwatch Luton.
Kate Robertson, I'm going to be Acting Corporate Director for Population Wellbeing. I'm here representing Mark Fowler. Thanks.
Councillor Rumi Chowdhury for BTO Ward.
Councillor Idris Latif, Wigmore Ward.
Councillor Zainab Raja, substituting for Councillor Nasser.
Okay, thank you. Can anyone who's joining remotely please speak and introduce yourselves?
Good evening. My name's Hannah Leask. I'm Head of Commissioning in Adult Social Care.
Good evening. My name is Harriet Edmondson. I'm a Public Health Registrar in the Public Health team.
Okay, thank you. Thank you, everyone. Just to say, I believe this is your last meeting, last attendance at this group, Nikki. Just to say on behalf of the group, thank you for all your hard work with this group over the past how many years it's been. My first meeting of in this committee was 2019. I think you were at that first meeting. I think in that time, I've had a growing appreciation of the openness and transparency that you bring to these meetings, and the fact that you're always willing to engage. So I guess from all of us, I hope you enjoy your well-deserved retirement. Thank you. Okay, the minutes of the meeting on the 18th of February 2025 are those a fair and true record of the proceedings of that meeting. Okay, thank you. Any disclosures of interest? Okay. Okay, any urgent business?
There's just one urgent business on the agenda at 4.1. That's circulated separately.
Okay, thank you. So yes, in the urgent business, we have an item from Adult Social Care. If we can take that item towards the end of the meeting, if that's okay. Thank you. Any references from committees or other bodies?
Chair.
I have nothing to report on anything that's happened since the last meeting. Okay, so I think that leads us on to item 7, infant and maternal mortality in Bedfordshire, Luton and Milton Keynes. Harriet, I believe.
Yes, thank you. Yes, thank you for inviting me to join your meeting. I'm sorry I couldn't join you in person. I'm just going to give you a bit of an overview of the recent infant and maternal mortality analysis, which has been carried out as a collaboration across BLMK with the other public health teams and with the local maternity and neonatal system. And this is in response to the concern and the identification that infant and maternal mortality is higher in BLMK than the national and regional average, and has been for a number of years, and the potential inequalities associated with these outcomes. So the aim of the analysis was to understand the scale, the nature and the causes of infant and maternal mortality to inform decisions around maternity services and wider healthcare pathways. So the Population Health Intelligence Unit undertook a data and needs analysis looking at all pregnancies in BLMK over the past 5 years. And we also undertook a review and a mapping of the existing services affecting preconception, pregnancy and birth to 1 year. So just to highlight a few key results from the data, we found that in the population of pregnant women across BLMK, there was quite large variations, as we might expect, in the deprivation profile and the ethnicity by place, with a higher ethnic diversity and deprivation levels in Luton. When we looked at the key risk factors associated with pregnancy outcomes, we found that pregnant women had higher levels of obesity and of smoking than the general population. And these were also highest in those of Black and Asian ethnicity and those from more deprived areas. So we see a sort of coalescence of some of these pre-identified risk factors. In Luton, we also know that there are high levels of close relative marriage, and this is why Luton is one of 10 areas in England that is part of an NHS England project looking at close relative marriage, which is associated with high levels of genetic conditions and poor outcomes. Looking at the antenatal care, we found that the booking appointment, which is the first contact with maternity services, there was a high level of that being delayed past the 10-week target, and this was highest in those of Black and Asian ethnicity and those living in more deprived areas. Another key aspect of antenatal care was vaccinations, and we found generally lower uptake of most of the vaccinations, in particular seasonal flu, at about 28% uptake. And again, this was lowest in Luton out of all of the places, and in those of Black and Asian ethnicity. When we looked at some of the key outcomes, we found higher rates of preterm birth and of the associated low birth weight in BLMK. And again, this was affecting more so that the same key groups, those who live in more deprived areas, those of Black ethnicity and those living in Luton out of BLMK. We also found that over the study period, there was an increasing rate of caesarean sections, and particularly emergency caesarean sections, which from previous research we know are traumatic and stressful for the family and are also associated with poorer birth outcomes. And this affected the same key groups that I've been mentioning. When we looked at postnatal care, one of the key things is the 6 to 8 week GP check as a point in the postnatal period that the mother and baby can have their recovery checked on, and the GP can ensure that the adequate services are in place. And we found this to be delayed in about 22% of the births over the study period, and this again affected Luton more strongly, those living in deprived areas and those of Asian ethnicity. One good news we found was that in Luton we have the highest rates of breastfeeding across the region, and this is higher than national average and has been increasing, and reflects some good local initiatives around breastfeeding that have been going on in previous years. Looking at the key outcomes of our analysis, we found that there were higher rates of stillbirth, of infant mortality, which is in the first year of life, and neonatal mortality, which is in the first month of life, higher in BLMK than national average, and highest in Luton in those living in deprived areas and those of Asian and Black ethnicity. And just to touch on maternal deaths, as that wasn't one of the key aspects of the review, Over the 5-year study period, there were 19 in BLMK, giving a rate of 0.05 per 1,000 per year. So thankfully, this is a small number of deaths, and the only issue with that is that we can't really draw firm conclusions about potential risk factors for maternal death, or whether levels are higher in those of by ethnicity or deprivation, because the sample size is too small. But we do know from national work that these are important risk factors as well. So if I could just draw your attention to the figure in the report. This is just a summary of all of these outcomes and metrics I've been talking about. The top chart is by ethnicity, and the bottom is by deprivation quintile. And with red being the shading being for poorer outcomes, you can see quite strongly this clustering of poorer outcomes in those of Asian and Black ethnicity in particular, and in those living in the first and second most deprived quintiles. So that really highlights those disparities there. Just to touch on the pathway review I mentioned, we did a survey and feedback exercise with all of the services affecting preconception, pregnancy and birth to 1 year. And the key challenges that were highlighted were around issues with funding, short-term funding or insufficient funding, affecting the service ability to deliver to the standard they wanted, issues with capacity and availability of service versus demand, issues with staffing consistency and staffing levels, and with integration and joint working between services. These were highlighted. Positives that were highlighted for the services were around staff commitment and dedication, the importance in services, particularly maternity services, of using patient feedback and co-production, and of personalised care. And importantly, these challenges and these positives were echoed in our review of service user feedback that has been collected over the past year, with a couple of additional issues identified in that service user feedback around postnatal support in hospital, and translation and communication difficulties if English is not your first language. So using all of this information, we came up with 17 key kind of recommendation areas. I won't go through all of them, but just to say that we're now working with the local maternity and neonatal system, the LMNS, on these recommendations. A lot of them are already areas that are sort of known about and are already in existing work streams, or will be taken forward as part of existing work streams. But as a public health team, we're going to be focusing on the maternal weight management, which is a really important risk factor, around working with maternity on the delayed booking appointments and understanding the trends in caesarean sections, on antenatal vaccination. We'll also be working with primary care on the GP checks and the issues with delayed GP postnatal checks. And we want to do some work around data quality and sharing between organisations, because this is a key problem the analysis team came up against in their work. So this paper has been a summary of the findings and recommendations of this review, and it is proposed that HSCRG receives updates on the progress on these recommendations in Luton. Thank you.
Thank you, Harriet. Just before I throw this open, I'd just like to say that I'm very impressed with the report, the format and the layout. It's very well produced. The data is very well presented. Even though it's a long report with the appendix, it was very easy to read and to understand, and it came with, certainly the online version came with a list of references at the back, which is always useful. So yeah, thank you for that.
Thank you.
Okay. Does anyone have any questions? Councillor Chowdhury.
Right, thank you, Chair. Thank you for the report. I was just wondering, I've been on this committee since last May, I'm just wondering, has there been a review done prior to May on this? And what were the findings in those reviews and how have we progressed against those? And in terms of your recommendations in the report this year around, I'm just wondering, the challenges we have is sometimes due to capacity issues. And has that been sort of included when, have you thought about those capacity issues when you thought of those recommendations?
Thank you. To answer your first question, this hasn't been done in this way previously. So this was done as a kind of collaboration across BLMK and is really looking at these risk factors using all of the pregnant women registered with GPs in BLMK and splits the data by place. So as far as I'm aware, there was no previous report the year before, and I'm not sure there has been one in this format recently. One of the kind of challenges of this area of work is avoiding duplication. I know that the LMNS has done bits of work around infant mortality, and so have the trust, but there hasn't been a formal report like this previously. And in answer to your second question around capacity, I know that obviously that is a real issue for the recommendations in terms of assigning responsibility to the maternity services, because they are obviously very stretched at the moment. They've received, particularly the Bedfordshire Trust, a lot of input and attention. They have sort of recommendations coming from their reports from different areas. So that is why we are working on the recommendations quite closely with the LMNS as kind of the conduit with the maternity services to make sure that anything covered in the recommendation areas that is already sort of a priority for them and the maternity services, we're not trying to duplicate what they're already doing, or so we're trying to kind of map out these recommendations to what they are already working on, and then as a public health team what we can take forward from a public health point of view.
Councillor Begum.
Hi, thank you for the report. My question is actually based on the page 12 table, on the metric table, and relating to paragraph 16. So there is a higher proportion of women not seen for postnatal, and on the report matrix, you said there is in the antenatal, you see there is a low percentage of people seeing within 10 weeks. Do you know the reason why that is? Why they're not seeing before and not after?
Yeah, this is a really important thing that we want to take forward when we're doing work around delayed booking appointments. So the data that we have does not give us reasons for delayed booking. That's not recorded routinely in the maternity services data set, which is where this information and the majority of the data comes from. So in order to take forward work on the delayed booking, we really need to work in conjunction with the maternity services to try and understand the reasons why some women are having delayed appointments. And all we can tell at the moment is the groups that are more likely to have a delayed booking, which I outlined in my in the report. So we do need to look at that. That's very important. There are legitimate reasons for delayed booking, such as transferring into the trust from another trust, and obviously that's important to separate out from other reasons. And I think what we want to work on is raising awareness in primary care and with the population of pregnant women around how to book and how and the timeliness, so that we can reduce the proportion that are just not booked late because they're not aware or they don't know the pathways or etc. So that's something we need to focus on some more. Thank you.
Thank you, Chair. Can I have a follow-up, please? So since we don't know the we don't have the data why that is. May I make a suggestion that when they do have their first appointment, that they are asked why didn't they see, or and afterwards, if they do attend with the child, to ask why they didn't afterwards. That will be helpful to collect the data to know why, because there could be various reasons. At home, for example, they could be a victim of something and they weren't allowed to attend. We just want to know why that is.
Yeah, I think that is really important. Thank you. And I think sometimes that information is collected at the booking appointment with the midwifery team. They will be asked why, either they will know already if it's a transfer of care from another area, or they can ask that, but it's not being put into the maternity services data set for us to access. So I think it'll be a mixture of that. But I think we do need to work with the midwifery staffing team around that as well. Thank you.
Faith?
Thanks very much, Harriet. That was a really good report, really interesting to hear about the work that's happening. And I do note that the Keeping Well in Pregnancy team at the Luton and Dunstable Hospital have done some really, really fantastic work, especially around smoking cessation in pregnant women. And I note that at times they've had some of the lowest smoking at time of delivery rates, both regionally and in the country, which is really fantastic. And it will be great to see that data coming through in more detail. I just wanted to ask about the work that's going on around tackling obesity. So you mentioned that would be one of the key priorities off the back of this report. And I wondered whether it's kind of a nationally driven piece of work, or whether it's something that's being developed specifically for Luton and the communities that we serve.
So at the moment, we've set up an implementation group which includes representation across BLMK. So I think we will be taking forward work on maternal weight management, as a team for BLMK. But I think there will also be some important pieces of work that we can do within Luton specifically, because I know that the maternity services have spent some time at the end of last year auditing their weight management referrals, and there's a group set up around that. So I think there is a mixture of some work we can do specific for Luton and across BLMK as well. I know that the smoking cessation service you mentioned within maternity services, we discussed that as a kind of a model of good practice that we might want to think about replicating for weight management as well, and having something sitting within maternity services. But we're still kind of at the stage of developing our thinking on that.
Thank you. Happy to be involved at any point. Thank you.
That'd be great. Thank you.
Hi, from Have Watched Luton. We've recently done a interim view at maternity. We are currently writing the report for that. I think it was March that we went through. Yeah. And I know that we're still getting feedback from that as well. So we'll probably be doing another interview at some point. But once we have that report, we're happy to share that with you.
Thank you. That would be really helpful. Thank you.
Yes, thank you. Anyone else? Councillor Chowdhury?
Hi again, Harriet. I just wondered, the booking system, is that online?
Yes, it is. Yeah, you can book just by going onto the Trust website and doing an online form for Bedfordshire. Yeah, it is.
Just to add, I mean, Luton has such a diverse community, and I myself personally am coming across a great number of people who are having problems even sort of booking online to see their GPs. So has that been factored in terms of, the assistance that some people may require when booking their appointments? And the other thing I was going to mention was the awareness raising. You're going to be using the family hubs. I mean, if they're very town-centric, etc., how are people, especially people from my ward, going to get that information decimated to them in a sort of format that they can understand?
I think that's a really good question, and I think that's something that we need to take forward in that programme of work around booking appointments. So thank you for raising those points. I think as far as I'm aware, there hasn't been much work done around the accessibility of the website and how that is being promoted, and that is one of the things that we want to look at. But we definitely need to consider different avenues for that promotion as well. Family Hubs is one important resource that we have that we can use, but we also want to work with primary care as well, because we know that some women, when they find out that they're pregnant, they will go first to their GP to ask about booking. So we want to just make sure that we've got a few different avenues for raising awareness about the booking process, and also about the process if you are booking as you want to book into it as an out of area patient, not into your trust within your area, because that is also a something that was raised in our patient feedback, and is a pathway that can present some additional difficulties for women as well, and for joining up the care.
There's nothing else. I've got a few questions, Harriet. You talk about the data collection and the maternal services data set. Is there, I couldn't see anything in particular in the recommendations about trying to improve the data collection. Is there any work being done on that?
So that is one of the areas that we do need to work on. So we have kind of the final recommendation about data recording and quality. So I think we found with the maternity services data set that there was quite a lot of missing data for some of the metrics, and which meant that we either had to supplement with other sources by sort of joining to primary care data that we could, by linking to primary care data, or we were unable to investigate some things that we originally wanted to. So I think that is an important aspect that we need to take forward around recording. And we also found it with some of the primary care metrics, as I mentioned, the postnatal GP check. There was, we were unable to determine if that 22% that were delayed were all because they hadn't happened, or because they hadn't been recorded adequately in the primary care record. So I think there's some work for us to do as an implementation group around working with maternity services and with primary care about data quality and recording of some of these key metrics. So we will be taking that forward as part of the work streams.
Okay. The rise in the number of emergency cesarean sections, the report mentions that I believe the report mentions that that's a larger rise for Asian and Black ethnic groups. I mean, is there a reason generally why there's a rise in the number of emergency C-sections?
Again, that is something that we do need to work with the maternity services around to see if there is any knowledge or experience around potential clinical factors. I mean, we know that in general, the population of pregnant women has been, over the study period, there's a slight increase in pregnancies in mothers of in older age groups over 35, and an increase in the rate in those of Black and Asian ethnicity and those living in more deprived areas. And so in a way we can say that there is potentially an increase in the complexity of the needs of the population of pregnant women over the study period, because we know that these groups have kind of, as I mentioned before, kind of coalescence of some of these key risk factors, and such as obesity, smoking, and we know these groups are disproportionately have higher levels of some of these poorer outcomes. So there might be a link to that, so a more complex cohort of pregnant women who are more likely to need to come into, having an emergency cesarean during their birth. But But really that is kind of, you know, we see that in our report, but we can't directly link that to the emergency cesarean sections because we need more contextual information, which isn't present in this data, maternity services data. So that is one of the recommendations that we want to take forward within our implementation group, working with maternity services to try and understand that a bit better.
Okay, thank you. The pathway review identifies some key system issues around information sharing and capacity. So, I mean, we're talking about short staffing and so the lack of systems in place to facilitate information sharing.
Yeah, so this is this information has kind of come from the survey which we sent out to all of the services across the kind of pregnancy and birth to 1 year pathway, and this is the kind of qualitative data that we were getting back from them, reporting around kind of a lack of joint working between services or a lack of information sharing, so whether that would be between primary care and maternity or different teams within the maternity service. So I think some of it is kind of an issue around, you know, the way that data is shared across the pathway and the kind of culture of joint working, but also we have on recommendation 15, we want to look at this a bit more and think about, are there any systems that would be more helpful for, you know, helping services to work together and to share data? And are there any kind of, you know, new pathways that need to be developed? And in particular, thinking about, again, those women who are coming in from out of area and how to make sure that their care is joined up between their pregnancy and their postnatal care as well. So, yeah.
Okay. So it was last September there were reports in the press about the Hospitals Trust making large payouts to families who had experienced birth trauma. Is there? I mean, that would seem to me that seems to imply that is there something else going on about birth trauma that's not necessarily to do with inequality, but is there a more general issue at play here?
So I think that we've obviously looked at this more from you know, kind of perspective, a public health perspective, and less so a kind of clinical perspective, as we know that the maternity services have done a lot of work around this. You know, I know there was a lot of attention on the numbers of maternal deaths, and the Trust did write their own report about that. And what we found with the maternal deaths was that less out of the 19, less than 5 of them were related to pregnancy and childbirth, but many others were related to other factors like malignancy and so on. But I know that when the Trust did their review of maternal deaths, which we did touch on in the full report, there were some clinical factors identified in some of the cases around things like the use of early warning systems, and you know, identification of deterioration, clinical deterioration in mothers and babies, and those I know are key priority areas that the LM&S are taking forward in conjunction with the maternity services. So though we touch on it on the report, we haven't looked as much at the kind of clinical aspect of the care within the trusts.
Okay, thank you. Does anyone else have anything else to contribute? Councillor T.
Thank you, Chair. Thank you, Harriet, for the report. Just want to clarify on the recommendations. There's obviously 17 recommendations. Will there be a review of the recommendations to see how progress has been made? Obviously, we don't want to wait for a year to find out, you know, things have not improved significantly? Thank you.
Yeah, so we are going to be, as I said, we've set up. We've only just had one meeting so far. This kind of core implementation group, which has the public health teams from Luton and from Bedfordshire and Milton Keynes on it, and we're going to be progressing those recommendations that I mentioned that are more kind of to do with public health. And we're going to be kind of keeping a regular review on the progress on those recommendations. But we're also going to be kind of because this is a sensitive area, and as I mentioned, the maternity services are very stretched at the moment. We'll be keeping an eye on all of the recommendations, but kind of gently checking up on the progress with the LM&S work streams. And we do have the LM&S representation on our implementation group as well. So it'll be conjunction between the two sort of working groups there. But we will be keeping oversight of our recommendations and how they're being progressed on a regular basis. And the governance within the LM&S on their recommendations is through their strategic programme board, which meets on I think a bi-monthly basis. So there will be more regular progress checks on this work.
Okay, thank you. There's nothing else. So just to sum up, this is self-evidently a very important issue, not obviously for the families involved, but also keeping in mind the Luton 2040 vision of no child being born into poverty. Then this obviously has a direct bearing upon that. We are recommended to note the report and continue maintaining oversight of activities relating to infant and maternal health undertaken by partners in Luton. And also, you mentioned, Harriet, that we should have regular updates, which I think we would agree with. So yeah, I think we can accept those recommendations. Yeah, thank you very much, Harriet, for an excellent report. Thank you.
Thank you.
Okay, we move on to item 8, primary care GP access.
Thank you, Chair. So I'll just assume everyone's had a chance to have a read, and hopefully people had a chance to have a look at the video in there. But if I just start, because I know we spoke last time about the practice having cloud-based telephony, I think that's a real game changer, because that has helped practices to assess the demand. What we had previously, for example, is if residents were ringing, it could ring out, and it was very frustrating. And that's frustrating for all, because the practices wouldn't have known people were ringing in because the lines were all busy. So that has been a game changer. So I think that's the first point, helping them to assess their demand and putting the capacity in. The point from Harriet's section about access, and you mentioned, Councillor Chowdhury, is it's really important that residents can still walk into the practice, they can still telephone, and they have the facility of the online. I do know that we hear reports where practices staff will say if somebody walks in, they've got to phone or do online. We will have to work on that, and that will be very much working with Faith and the team on a case by case, because that isn't the case. And we've had experiences not in the Luton system, but of people who are deaf that clearly can't use telephone, haven't got. So we are very, very sensitive to that access point. I think it is important to note that, of our population a bit younger, they do like online. So you'll see that the online is really popular in some areas, which is great, because that helps to manage the workload. I think it's worth also noting there's 8% more appointments. And I'm not necessarily saying that's a good thing or a bad thing, because it could be a bit widget counting. If you have longer appointments, you might get more done, so you don't need them. But I just think it's important noting that there is that increase, which is a bit of a trend that we're seeing across the rest of BLNK. And equally, I think that's on a national level. We are very fortunate because we've got the strategic clinical lead, Dr. Monjur Ahmed, who is brilliant. He's our also local lead, and we do a number of lunch and learn sessions, and that is where practices have worked. Now, I've put in, because sometimes we use jargon, and I try not to, but Modern General Access Programme is a really comprehensive programme. And as I mentioned, the cloud-based telephony was one of the game changers to start it. But I cannot tell you enough of the work involved at a practice team level. So your front of house are critical, your nurses, your physios, your paramedics, and equally every single GP partner. And from the lessons learnt from implementing what we call this modern general practice, it's something called triage. And to demystify, it really is helping the practice staff to access the right care for the right person. And in fact, Dr. Ahmed does an amazing job at saying to patients, look, I know you might want to see me, but my physio or my paramedic or my pharmacist can meet your needs. And at a later stage, if you need higher complexity, I'll be here for you. So it really is taking the community, on board with them. So it is, and we don't get it right every time, and the practice recognise that, and we want to try and get that, continue, learn. And as I say, there is about, on an average day, over 5,500 appointments. You're not going to get it right every time, and we will work with you. So that's the first part of the report. The second part, which I thought was really important to explain, is the two practices, Birmingham and Kingsway. And in fact, we had the providers here previously presenting, and they were run by East London Foundation Trust. So their board made a decision back at Christmas time to withdraw providing primary medical services. They wanted to focus on their mental health and community. So that has meant that we, the ICB, have undertaken an expression of interest. And what we have used, and we've used it through our primary care strategy, we would look to local practices, and it was open to anyone in Bedfordshire, Luton, Milton Keynes, to take it on as a branch, and that added a bit of resilience. If we go to another option, which we have done in Luton previously, what we call an any provider, so it's called an APMS, it means that the contracts are less and it's more anxiety for staff because you can't give a contract for more than 5 years. So we went through the expression of interest, as I say, with any practice who had an established general medical services contract. And I have to say, we had a very, very good response, large number. So we have offered, we're in negotiations, practices, the opportunity of a branch. We're very close to finalising the negotiations, and we generally have contingencies. So we had, it wasn't just one practice, scraping along the line. They were good calibre, which is really reassuring for me. So we will be in the position in the next week or two. So those services will continue in the same way, and we've done correspondence out to patients, and of course keeping the staff up to date and so they're aware helps for the patients. But we've done communication across the piece. So those contracts on the 1st of July will have a new provider, and we are going through the process of something called TUPE, which is the transfer of staff. So it's to try and keep as little, or keep the stability. So it's, good for the patients, good for the staff. So that is on those two practices. And then I think the only thing I would then say is it's not so much in the report, but we are really promoting pharmacy first. So our pharmacy first, and there's a number of pathways, and we've done a presentation here, but it really is encouraging. We've got some fantastic pharmacists in Luton, really encouraging people to think, okay, can I go to the pharmacist? And the pharmacist is very good at supporting, and if not, they will give you, they'll signpost you. So I'll take any questions, but that's just the highlights of the report.
Okay, thank you. Councillor Begum.
Thank you, Nikki. Thank you, Chair. First of all, I do think, happy to see the result of this report. There's a few changes, and I do think the system is a good system. It does work for those who can use it, especially people like me who can go online and just fill it up. And I have found it very useful recently, but also it is still lacking on some of the people who don't speak English or don't know how to use it. I think at the last meeting, I did ask for some feedback from residents at certain surgeries or all surgeries to see how they think about the system. I didn't see any in the report. Can we still have that, please, if possible?
So I might also look to my Health Watch colleagues because they work really closely with us. But we really support the practice with their patient participation groups. And again, that is very much identifying and hearing what the issues are. Equally, in the report, we didn't mention about the NHS app. And the NHS app, although it's a national app, it's how we use it locally. So in the Luton, and this is very much with our pharmacists, we've used that to good level for people wishing to have repeat prescriptions. So we've actually put some sessions in where we've helped people. Once you've done it once, it's quite straightforward. So allow me to hand over to my patient participation group. They may have heard through that. I don't know if you've had anything. No, you haven't. No. Okay. It is certainly something that your reports emphasise, because primary care access to general practice is probably the key. We can certainly do that for a next one. What we've also within primary general practice is that it is a 24-hour service, and sometimes particularly people that aren't familiar with our systems, is that if you ring the practice telephone number and it's the out of hours, so when the surgery is closed, it automatically goes through to the 111 provider, and where you then will be, you'll process. But I'll pull that through. We do have the patient survey results that has come through, and it has improved. And interestingly, the out of hours period is slightly superior to the in hours, but then that's probably because the demand is less. So you have to be careful how you read through. But I'll take that on board for patient feedback.
No, I agree. The app and the system is a good app. I do, as I said earlier on, it's a good app for those who can use it. But I think, I don't know about my other colleagues, but I'm still getting reports of residents who are not able to use that they can't. And you did say that some surgeries are allowing people to go in, but some aren't still. So someone can't go in and make an appointment. So I just wanted to see the residents' point of view. It's all fair. We can say that yes, it's working, but what about those elderly people who can't use the technology, or ethnic minorities who don't know how to speak English? I just wanted a feedback from them, rather than us deciding something good for them without them telling us if it's good or not. Yeah, thank you.
And honestly, if we hear anything, because we have, and it's through your soft intelligence, sometimes it can be a member of staff, front of house, that just doesn't know, and they're feeling they're doing the right thing. So we just have to keep going around that loop and just saying exactly your point. They will encourage. So if they think someone can do it, they will encourage. So it's that level of whether it's, encouraging, it's about getting that relationship right.
Councillor Chowdhury, then Councillor Mead.
Right, thank you for this report, much appreciated. And it's good to get some sort of feedback about how this is actually working within Luton. I just wanted to know, or I want reassurance that, individuals, how all the surgeries are dealing with this access issue and the new way of actually booking appointments and how it's working with their patients. Especially, I don't know if I mentioned it last time with you, and it could be specific to individual surgeries and their front of house and the lack of training amongst front of house staff. Is one particular lady, she's been trying to get an appointment during the winter months with her surgery. She couldn't get herself understood over the phone. On one instance, she went into the surgery, sat there for over 3 hours, and no one even gave her an appointment or found out what she needed or what she wanted. And afterwards, I picked up and I rang the surgery myself, tried to get an appointment with her. And they did agree that they have someone there who speaks her language. It's just no one's bothered to find out why this lady is presenting at the surgery and sat here in the surgery for over 3 hours. So, I mean, it'd be good to know if individual surgeries are being sort of contacted to find out how this is working with their patients. And if some piece of work could be done in terms of feedback, as Councillor Begum has suggested, from patients themselves to see how patients feel that this is working for them or if it's not working. And the other thing about the telephone service, it's good to know none of the telephone calls are being missed now. It works perfectly well with me. I mean, I love it now because I can just, ring once and ask them to call me back. And yes, someone calls me back. It works brilliantly. But I'd like to know, although none of the phone calls are being missed now, what actually happens? What's the outcome of those phone calls? So we have an increased number of people ringing in, but what's the outcome? I mean, are they all given an appointment, or are they all sort of told to go online and book an appointment? What actually happens? That'd be good to know in sometime later. Thank you.
Okay, thank you, Councillor Mead. And then Councillor T.
Thank you, Chair. My worry is all this reliance on the technology, on the internet and one thing and another. My wife, I tried to get her at the NHS app on her phone, but it was too old and won't support it. And I know a lot of my constituents who are of my age have still got little pay-as-you-go phones and are not on the internet. We still need a telephone service. They spent their lives, they picked up the phone and made an appointment. And somehow we just got to wait for them to sort of pass on, as it were. We should still have a service where people can just pick up a phone and make an appointment, give their concerns or whatever. Yeah, that's about it. Not too much reliance, or not totally relying on people having the right app or having IT skills which they can navigate their way around on.
So I do emphasise that is what contractually, that's what the practices have to do. And that's what I'm saying, to be able to do it over the telephone. What they are requiring, and it's a national programme, is where people can use IT and online. And a lot of people do want it, and a lot of people like it, have chosen it. But I absolutely take on board. I've got an 89-year-old mum. She wouldn't even know how to log on. She's got a phone, but she wouldn't know how to do it. So I absolutely take your point on board.
Councillor T.
Thank you, Chair. Thank you, Rwanda. Thank you for the report. I just wanted to clarify. I live in the Beechwood ward, and Kingsway is one of my nearest surgeries. It's in the building where there's Conway Medical Centre there as well. So there's two different surgeries in one building. So I had a chat with the GP that's running the current Conway Medical Centre. Obviously, it doesn't make sense having two separate services in one building because it's not very efficient. I thought, has any effort been made to get existing surgery in there to take the patients on from Kingsway? So Conway Medical Centre taking the patients on for Kingsway.
I just want to clarify, because that building we utilise, and I think it came here a few years ago. So we've got greater efficiency of two practices being in there, and they actually they've got a bit more sustainability because they can use each other's waiting space, etc. So is your perspective that it's not efficient by having two practices in there?
Duplication of, you've got frontline, you've got two desks by side by side, so you're duplicating the service. It's not very cost efficient. How can it be? So
there are two separate practices utilising the same building, and as you're aware, is that as part of the GP contract, is that the rent and rates are reimbursed. So we have made cost efficiencies by the use of the building. If you're saying the way they work, that is certainly something that I can get the primary care team to work with both providers, but that is, you know, that will be their business in the sense of how they are operating their you know, their actual business. But happily I'll raise that because your perspective is helpful. But equally, if you say you've spoken to the GP already, what have you got a recommendation that you think that we should be doing?
I mean, obviously, it made sense for the practice that's there ready to apply to take over the other Kingsway as well. So I encourage them to do that, because obviously it would make a lot more sense where the patients are used to the building. So if a new provider comes in, it's got to build a relationship with the with the existing patients.
I don't hear what you're saying on that.
So I mean, they know the staff, they know the environment. Conway Madison is doing a fantastic job. I mean, generally, obviously, we like to moan about our GPs, but they are doing a good job. So, I say it would make a lot more financial sense to.
Okay. Yeah, I hear what you're saying. So what I would give you that assurance is that the procurement process that is, it's a very diligent process, equity fairness. So, one hope you have to trust the process. That's what I would be saying. So, yeah, but I hear what you're saying. I've got you just now. Yeah.
Thank you. Just a couple of questions, Nikki. I've raised this one before. It's we're talking about improving resident experience of access to general practice. Is this a consistent picture across the town and across the PCNs?
We still have variation across the practices and the PCNs, and that really is what our clinical lead is about, sharing the data and really encouraging them. And it's that way of working. So I would be, as you said at the start, I am very open. There is still variation, and that's why those lunch and learn sessions that Monjo Ahmed runs is really critical. But and it does need the whole team, and it is that whole team effect, including accessing, like pharmacy first where it makes sense. But the gap is getting less. Yeah.
Okay, just one more. So this is some more anecdotal evidence. I know a couple of people who suspect that they're being guided down the most convenient treatment pathway rather than the pathway that they need. I mean, presumably it's obviously not the practice to push people down a pathway that's the cheapest or the most convenient rather than the most appropriate one. I mean, can you reassure us that that doesn't happen?
So again, because I've listened to many of the sessions with our clinical leads, it is about getting the right person with the right skills. So, and it isn't actually about money. It's about capacity. You've got a finite resource, and we know that our GP numbers are lower. And we've got lots of initiatives to encourage. So we've got training practices, because all the evidence is if you learn and work in an area, more likely to stay. So we've got a lot of initiatives of training. We've got a lot of initiatives of what we call late careers and encouraging people to go part-time and carry on doing a bit. So it isn't about cheap. It's about having the right staffing mix. So I can confidently give you that it's not about cheap, it's about getting the right workforce.
Okay, thank you. If there's nothing else, okay. Oh, Councillor Lampier. Yes, please go ahead.
Thank you, Chair. Yes, so my colleague they previously mentioned about this telephony booking issue, right? So I'm just making a follow-up questions. I know it's a good service for people who are young and who are computer literate person. So I can hear lots of people are elderly or who doesn't have a internet access. They're finding difficulty. Is there any chance you can put some quota system for people? A certain number can book through over the phone, or like maybe 20% of number can be booked for walk-in or telephone, because still there's a large number of people are struggling to book online. Because I have seen my staff, they are very excited to use the system because they are IT literate, and early morning they jump. But my mother-in-law, she's elderly, she doesn't have anybody couldn't help, but she's struggling. So it is a very unfair system. So I think you should consider some sort of quota system for telephone booking or walk-in service that can balance. This is my comments, and if you can
go back to that, it has to be a delivery model on need and not allocations. So in some areas, it needs a higher number of people walking in, a higher number of people telephoning. It really does need to be on need. And we've got to together make sure that we don't see anything about being unfair, because if somebody has the inability, doesn't have the kit, or doesn't have the confidence or to do the online, they can't be disadvantaged. And that's where I say that with a personal, commitment, if there are any practices, because I have had it, and somebody in the team literally goes to visit. We also encourage through Health Watch to do some mystery shopping as well. So it really should be on need and not on quotas, is where I would say to any other practices. And we do monitor, so we would know. Because
in terms of GP perspective, they're running by the business. Because when I talk to GP, they wanted to fill their number as soon as possible to ensure their slot is booked. Because thereafter, each patient they'll get a they'll get a revenue. But they are they don't wanted to leave it uncertainty. Or if the 20% is not being filled, if no person. So if you give it flexibility to GP, they will choose the online option, first come first service, because they would like to get appointment slot block to ensure they are getting business, they utilize their slot and getting the revenue. So I think ICB should make some sort of decision. We shouldn't rely on the GP, because GP will say no, we prefer first come first service. Because so we need to be it will be, it not make sense. It can, so we need, ICB should dictate, get the data from local intelligence and just say, okay, this is the policy, and all GP should be follow this one. Because if you wait for the GP, they will love to their things on their own way. They will look there after the business, because GP service is the business benefit.
I think it's really important. I need to make clear to this committee, there is no payment mechanism, or if they see a lot of people or they don't see, it's not about numbers. So if a practice, and in fact some successful practices, it's examples of good practice in London, where they've got lots of slots, so they can do some proactive work rather than reactive work. So I confirm that any GP practice in England is that there's no payment for how many appointments they get filled. However, people like me will be saying to practices, what is your capacity if I've got a whole load of people that are saying they can't access? So it is that balance. But now we've got the cloud-based telephony, we can see the missed calls. We've got a database that it's a big old database, and I'm 95% sure it's accessible to the public. I'm sure it is, but it takes a lot of analytics, and you could spend all day trying to make head nor tail of it. But for me, the important thing is that we know of all the appointments made across BLNK. So we have about about 126,000 appointments. Is just about half. It's about 49, 51 often. So 51 are non-GP, and all the others are clinical, that range I mentioned earlier. There is some practices have a higher number of online appointments. I think in the BLMK of the 84 practices, I think the highest is about 40 online. We have some practices that are about 5 online. Well, you could say, well, actually, if you want online, you're not getting a service. So, but we have to work, I have to work on, it is a clinically led, the GP partners, there's always more than one, are clinically accountable. They have vicarious liability. They will do a clinical assessment. So it's the appointments is about meeting demand and need. Yeah.
Okay. Thank you very much, Nikki. When recommended to note the improving resident experience of access to general practice in Luton, I think we can do that with the proviso that we take all of our residents with us in that. Okay. Moving on to the item of urgent business, sorry, I must apologise, I've forgotten your name.
No problem, Chair. It's Catherine Dokia, Head of Provider Services. I report into Jill Britton for Adult Social Care, but Hannah, my colleague, is actually going to present the report online.
Please go ahead, Hannah.
Thank you so much. I've just got a few slides that I will bring up if that's okay with everyone. If you give me 1 second. Okay, can everyone see that okay in the room?
Yes, we can. Thank you.
Brilliant, thank you. So yes, as Catherine said, we're here tonight on behalf of Jill Britton to talk through the report that you've all had a copy of, which outlines the work that Adult Social Care have been doing, but crucially not just within Adult Social Care, but across the whole of the council really, and with our partners to strengthen our early intervention and prevention offer. So just a little bit of background. The Care Act really clearly defines what they mean in terms of prevention, reduction and delay, and places duties on local authorities and partners to make sure that there's really robust services in place that will ensure we have those pathways in place. So it's a statutory responsibility, but also something that's absolutely integral to our adult social care strategy and the 2040 vision, which sets out how we want to improve population wellbeing and tackle health inequalities to enable everyone to have a good quality life and reach their full potential. So the report that you will all have received sets out the work that has taken place over the last 12 months to really strengthen our offer in this place, and give an update on the report that you would have received, I believe, in February last year. So just a bit of a reminder here, again, this is in the report, but a bit of a definition here on what we mean when we talk about prevention, reduction and delay. So prevention is obviously for everyone. Our aspiration is that around 70% of people will have their needs met within this kind of the top part of this, this diagram here, which is very much about having really great universal services in place, really robust information, advice, which will mean that people can avoid the need for care and support developing. The second layer there is the reduction level, so that's kind of secondary prevention, which is more targeted and looks more at individuals who are very much at risk of developing needs where support may slow this process or prevent other needs from developing. And the top bit of the diagram there is around tertiary support, which is the delay layer, which really focuses in again on those people with more established and complex health and social care conditions to minimise the effects and support them to regain skills and reduce their needs wherever possible. Obviously, what we want to achieve in Luton and as a system is a really robust set of services across all of those different levels of support. So what you've got within the report is work that we've been doing, particularly over the last 12 months, to further embed and develop our support offer within each of those 3 layers, which I'm going to talk through very quickly now. So within the prevention space, the kind of primary support layer of that diagram, we've done some really extensive co-production with residents last year. I think it was in the summer of last year, which really helped us get some great insight in terms of how well we're meeting people's needs in terms of the information that we have available, predominantly online. And as detailed in the report, that told us what we're doing well in that space, but also set out some areas that we really need to improve, and talked about the importance of getting that communication right and getting that information correct and accurate. That co-production has enabled us already to make some positive changes to our existing web pages and inform the introduction of stronger online self-assessments. It's also, though, crucially been fed in. A lot of that feedback from those co-production sessions has been fed into the broader corporate transformation programme on resident experience, to make sure that that learning is also built in there. And there is an acknowledgement that there's further work required around our website that's going to be looked at as part of that project, which will take a bit of time and resource to fully realise. But we feel we've got a good evidence base on which to base that. Another positive bit of news is that 98% of our adult social care workforce have had really detailed training in co-production, which means that everything that we are delivering and shaping and designing will have co-production at its core. We've also, as detailed in the report, done some quite detailed analysis of contacts to the council. So as set out, our target operating model is that around 70% of people contacting the council will be able to have their needs met at that first point of contact via information, advice or universal services. The detailed analysis that we did at the kind of back end of last year and early this year told us that there's some way to go with that we've still got quite a lot of those people are not having their needs met at the front door, but having to kind of have secondary referrals over to adult social care, but also gave us some really useful evidence and intelligence on which to build our improvements so that we can move towards that operating model being a reality. Another bit of good news is that we did have, there was an independent evaluation that was done recently by a carer support organisation that actually identified Luton as being the top performing borough across the east of England in terms of the quality of the online support that we have available for carers. That's something we're very much looking to build on and further improve. But again, that was some nice kind of positive feedback that was received. In terms of the second section of the diagram and the reduction layer or the secondary support, largely that work has sat within two areas. So the first one really, I think, builds on the work I described in the primary layer and looks at how we can kind of take whole system redesign to improve access to universal services via our voluntary and community sectors. So not just thinking about improving the quality of the information and advice we have online, but how we can actually work with our partners, work across community hubs, with our health partners, with pilots that we're running through the Luton Integrated Neighbourhood Collaborative or link, to make sure that the information that is needed for people can really be cascaded and met through those kind of forums. I think we're saying we're kind of at the start of the journey there, but we're really looking to build on the foundations that we've got in place, particularly as we develop our neighbourhood model over the next 12 months, which means we'll have far more kind of join up and multi-agency responses. The other piece of work that we've been doing more closely within the adult social care space is further developing our PEP pathway, so our prevention enablement pathway, which is a specific service which looks to provide targeted short-term support to people who are what we'd say kind of on the edge of care, to facilitate proactive enablement and support residents to live independently. So particular areas of note within that space, we've recruited a third local area coordinator to the Farley ward, and a fourth is being recruited to Loseley. There's been some great work around some targeted falls prevention work, which we know from various bits of research and in our experience, falls is obviously a major one in terms of that prevention. If we can do more to prevent that, that will absolutely reduce our pressures. We've also been commended by Sports England for our collaborative work with Active Luton, so doing some really targeted work to promote physical activity to those who we know are at risk of losing their independence. And we have delivered focus work via public health grants to support adults with a disability to secure and maintain employment with support, where, as detailed in the report, we are operating above the national average. And then the final section in that kind of tertiary or delay space, we have continued to support the BLMK DISC programmes, the Digital Improvement to Social Care programme, which has seen us pilot and evaluate a number of different technological improvements. And the learning from that is very much going to be built into a technology-enabled care strategy for Luton over the next 6 to 12 months. And I think this is something that will absolutely support in that tertiary space, but in theory also support across all of the other layers as well, depending on the scope of that strategy. But there's some really great opportunities in there to use technology to build independence and to reduce delay as well. We have, as part linked to that, strategically been linking in with some early work that's taking place to review the council's existing assistive technology service to kind of support that evolution, to ensure it provides a modern, proactive, preventative and data-rich service moving forward. We've retendered our community equipment loan service in partnership with our neighbouring boroughs, and that contract went live with Mediquip in April 2024, and as detailed in the report, we've seen some really great performance from that contract, some really great high levels of resident satisfaction, and as detailed, we're kind of being able to demonstrate how that support offered via that service has helped residents do hospital discharge and also prevented hospital admissions. We've also done work in terms of the disabled facilities grant, and so managed to kind of increase the use of that grant to enable people to have adaptations to their home, which will enable them to remain independent for as long as possible. And we have plans in place to recruit 2 new occupational therapists to support the waiting lists in that area. The reablement service, Catherine's here, she might be able to say a bit more about that if needed, but the reablement service has also been expanded to reach more into the community, taking residents from the community as well as the hospital, to really have that focused piece of work to get people back to best. And we're doing some ongoing work around how we review and redesign that service in partnership with the hospital. And the last thing to mention here is that we've launched a kind of specialist multi-agency service or project to do some really targeted work with people who are displaying hoarding activities, recognising that can be a really big barrier actually to people being independent. So that's started up, but we've seen some really positive numbers going through that, which we will be continuing to evaluate and evolve. So yeah, in terms of the summary, really, I think this is really just an update for the group to note, but it hopefully sets out some of the key changes and developments that have been taking place over the last 12 months, not just within adult social care, but crucially with across the whole council and with our partners, to really evolve and embed our approach. And there is more to do, absolutely, and we recognise that. But I think what we're saying is we feel there's been some significant progress made over the last 12 months that we will be building on further as we move forward. So I hope that was helpful. Obviously very happy, Catherine and I can take any questions that people may have, or feedback would be really welcomed.
Yes, thank you, Hannah. That was helpful. Does anyone have any questions? Councillor Begum.
Thank you, Chair. Thank you, Hannah and Catherine. I have 5.5 questions. I'll try to be, do you want all at the same time or one at a time?
One at a time will be fine. Thank
Okay.
you, Councillor.
Okay. First of all, thank you. Such a good report and to see some great results in there. And I'm glad you mentioned where further work is needed, especially in the neighborhood area. I'm also glad to see the section on hoarding, the project on hoardings and self-neglect. I'm really pleased to look forward to the report on that one in the future. And the Tom model, I think it is a good model and I'm sure it will work better. So the first question is on paragraph 18. Can you expand a bit more on that one, please? On the PEP. Yeah, what sort of activities taking place? I know you said you supported 28 people, so just a bit more further information.
Take that one. I can take that one, Councillor. So paragraph 18 is in respect of the hoarding forum that we've got. So we did recognise over the last couple of years that that has been a significant problem in Luton, and it's also not a quick fix for the people that are in those living environments. So actually that takes quite a sort of comprehensive bit of work and taking someone on a journey that can obviously take a lot of time. So what we thought our best approach was to have a multidisciplinary approach. And actually we've got like a model that we work to see where someone lands on the hoarding scale, and depending on that then we look at what interventions we can provide that. And because we've done those pieces of work and we've had those forums, we've recognised actually there's quite a few people who need this support, so we use some of our resources to recruit 2 specialist workers who can offer those people some really focused interventions. And that means, sorry
Catherine, just to interrupt, what I was hoping what I'm looking for is what activities actually you did with just two from the 28 people. So what kind of activities taking place with?
So a case study, do you mean that type of thing? So it would be that we'd start to get to know the individual, and we'd start to help them get the access to services, be that mental health service, or be that slowly get to know them, help them to start decluttering and looking at the risk, because you can't just go in and start saying to people and about decluttering their environment. In a lot of cases, councillor, it takes a long process. So those dedicated workers can spend time with those individuals, getting to know them, getting them the access to the right services, and then start helping them to manage their environment in a way that manages the risk that it poses to their health. So that's the type of work that entails.
Thank you. So I'm sure we all know this is very very difficult thing to get rid of from people. So I just wanted to know, how is it that...
It's helping individuals manage their situation and making sure they've got the right access to the support to empower them to do that.
Okay. Thank you. The second one is, how will we measure and track the long-term impact of EIP? Especially improving residents' outcomes.
So we do measure outcomes, and we can do so, and we can provide lots of sort of case studies. And again, we get lots of feedback from individuals that have been supported through EIP, and that might be from access to work. A lot of the things will be how we've connected people to local community organisations, especially in terms of managing isolation. So we get lots of feedback, and those outcomes are measured. And I think the real data that we'll be telling is whether people come back to us with that same problem. So that is measured, and we do get lots of really good intelligence from case studies and feedback. And we collect all those stories of difference, especially as part of our sort of CQC evidence-based methodology.
The third one is, what is the timeline and resources plan to fully implement the neighbourhood model?
We're at the very early stages of that. It's a much more broader piece of work, councillor. So it's not just about adult social care. It's an integrated piece of work. What I will say, though, is through our TOM, which we're in the middle of, starting this sort of organisational change assessment, that will be the very first step that will look at locality working. So and that's the biggest start, isn't it, where social workers are assigned to areas of the town, and where we can then integrate with those other services that are in those those areas. So I can't give you a definitive response about the timeline, but I can say I think from adult social care, getting locality working is one of the very first steps in that journey.
Thank you. The fourth one is, how can you make sure that it's sustainable funding to work for capacity, especially occupational therapy and LASs?
Sorry, Councillor, I didn't hear that one. Apologies.
How can you make sure that it's sustainable, especially when it comes to funding and workforce capacity, especially when it comes to occupational therapy and the local area coordinators?
So the funding.
How can you make sure those are sustainable so that they don't just go away?
Well, we would always try and protect frontline services. That's, because we have a statutory responsibility. And while budgets are shrinking, we do deploy our budgets where for the areas of most need. And we'll always apply for grants that are available. So previously, our local area coordinator was grant funded. And then it's just about looking at our budgets and where the priority need is. So at the moment, our occupational health, you'll see from our DFG grants, we've been able to fund an extra occupational health therapist. So it's just about utilising our budget where there's the most need and, applying for grants that we can apply for, being a council.
Okay, thank you. So the next two are kind of mixed. Was there a reason why Farley and Lucy have the coordinators? Was it just ward related or are they for the whole town?
So when we very first started on the journey of local area coordination, we looked again at need. So it's about what areas had the most need for a local area coordinator. So I think we started off at I think it was Biscot and maybe Birmingham, a lot of older people in Birmingham, very isolated. So that's how we made those decisions. But now we've got the additional funding that we can then spread this service across the town. And also you have to appreciate that some areas are smaller and one local coordinator could maybe cover the two areas, especially if the wards are closer together.
Okay.
It's always based on need and priority.
Yeah, no, I thought so. I just wanted to confirm. Thank you. And the last one is not questions. Are you still going to the Let's Talk events to raise awareness of the service?
We do if there's a need. I think local area coordinator.
You went on the last one I remember you came to us 2023.
Okay.
It does, yeah.
So I'm not sure if the local area coordinators are going to them. I can find that out and come back to you.
I think it was really good if you carry on going to those, because then residents can know what you are bringing out, especially the neighborhood model and the TOM as well.
No, I appreciate that. I'll take that on board and I'll find that out and get back to you. And if not, I'll make some recommendations to them having a presence at those surgeries.
Yeah, no, thank you. I think one of the other, it's not a question, it's like a comment. I don't know about my colleagues, but I think in the South Asian community, there is a huge hoarding issues. It's generational. So I think it would be really good if you can raise more awareness of it, of the service, the project that's coming up. And maybe as councillors, we can do some work around it. If you want, we can bring you to come to somewhere in our wards and do a session on it. I think that would really help.
Thank you, Councillor. I'll take that back to the team and see what we can, how we can work collaboratively together to take that forward.
Okay. Thank you.
Thank you.
Thank you.
Thank you. Anyone else? Councillor Chowdhury.
Right. Thank you for the report. Very positive, I must say. But one thing that Councillor Begum was talking about, the local area coordinator. He said it's based on needs. Is there anything in Beach Hill at the moment? I mean, do we have a local area coordinator in Beach Hill?
I'd have to confirm that. I'm not sure if there is. I'd have to find that out. I can get back to you and come back to you about that.
Yeah, because I mean, I would have thought that there would have been a high level of need in Beach Hill. I mean, over and above what there is in Biscuit. You mentioned Biscuit as an area of high level of need. As I said, a very positive report. We know what's working well. Do we have any metrics of what's not working well? Because I've got personal experience of someone trying to access adult social care, and it took and this is someone with high level of complex need, and it took from September last year till February or March this year to get an assessment done.
Yeah.
And that's not working so well, is it?
No, I mean, we still have our challenges, and our waiting list is one of them. And I'm sorry to hear about that wait for that individual. But what we are trying to do in terms of our waiting list is, again, sort of triaging, on a regular basis, and we prioritise when people are referred into the who's, at the most critical need, and we look at that strength-based approach. So that is something that we're working on, and we're looking at sort of adopting a waiting well protocol. So while someone is waiting, that they are contacted by the service to see how they're getting on, to see if their situations have changed. That's very much in the very early development stages. I will say though, whilst we do have waiting lists and that is a national problem, our waiting lists are going down. Slowly but surely they are reducing.
All right. No, thank you. That was all. I mean, if you could sort of bring back something in terms of what's not working so well in Luton, what the needs are according to the different wards as well, that'd be really good to understand. Because the other thing you mentioned in your report is about the website information on for carers. Being recognized as a good piece of work. But I mean, do we know the level of unpaid carers we have in Luton and how they are accessing the information and services? Because I mean, if we're just basing on people accessing our services as the number of carers we have, that doesn't give us the whole picture in Luton. The other thing in terms of the hoarding, it'd be good to know, I mean, what the referral process is for that, because does that come through safeguarding or normal adult social care? Is it the care assessment teams?
Okay, so a couple of points to note. So yeah, we could come back on like an update about our waiting lists and different offers in the different wards. In terms of the hoarding, sometimes that does come under the safeguarding banner. The situation could happen, and the fire service could make a safeguarding alert. But alternatively, it also can come through the care and assessment referral stage, because obviously social workers would go out and see someone's environment, and it's one of those holistic approaches that could make you, enable a person to get through that pathway. Sorry, what was your other question? So it was about the waiting well. Oh, about carers. So yes, I suppose there is a difference between the number of people that are receiving a service as a carer and the number of people that are actually registered carers. And that did come up in a recent ADAS forum, that actually some people don't recognise themselves as carers. They see themselves as family members just supporting their loved ones, and that's what they're expected to do. So they don't actually formally recognise themselves as carers. So I do think we've got a bit of work to do nationally, regionally about that. But no, there's some data that we could come back to you about. And there is also like a carer strategy with an implementation plan. I think Hannah's got her hand up, that we are working on as well, Councillor.
Right, thank you. Just quickly, is there a referral process? Because just put my hands up, I work for a local advice agency, and the work you're doing on hoarding, we haven't learned about that, if there is a particular sort of referral process for that.
It will be your usual referral process for adult social care. Yeah,
Thank you.
It's exactly that pathway.
Thank you. Did you want to come in, Hannah?
Oh, yeah, I think Catherine's probably covered it, but I was just going to mention as well that I'm really happy to also share the independent report that was done in terms of the methodology that was used to kind of rate the different local authorities and their support and availability and information and advice for carers. But yeah, as Catherine said, we have got a carer strategy here in Luton, and as part of that, we're doing quite a big piece of work to think about how we can better join up some of the data that we have in different spaces to get better understanding of where our carers are, but also as part of that, a lot of work around raising the profile of carers. We've got Carers Week coming up, and we're constantly kind of trying to think about ways to engage with different parts of the population, different underrepresented groups within our carers data to kind of identify those hidden carers and bring them into services and make sure they're getting the support that they need. So yeah, just to note that we recognise that's an area, and there is work happening via the strategy to support that.
Thank you. Councillor Ross.
Thanks for the report. I just want to ask a question on point 11 about the alongside the health neighbourhood offer about the link. I just need to know, you might not be able to answer it now, but if you could come back to us about how often they meet and how many people actually taken this up or attended the sessions, I should say.
I think we probably would need to come back on that specific data if that's okay.
Okay, yes, please. I'd like that. Yeah, that'd be good. Thank you.
Anyone else? Yes, go ahead. Hi.
Thank you for the very productive, informative report. I just want to, it's more of a comment actually. I want to thank you for the work that you're doing in Briscoe. I don't think my colleagues are aware, but we've got quite a bit of care homes there, and especially Abigail Close, where we have adult assisted living there. It's great what you're doing with the care home, but I'm working a lot more with the people that are living on their own, and it's very isolating for them. I've got one case where a gentleman's not going out, and when I've been referring him to adult social care, it's because it's not affecting his mobility, hence why he can't have a social worker, and he's so adamant that he wants a social worker. So I was just hoping there was a way that we can work around people that have social anxieties with the elderly that are in their homes a lot more.
I think, again, that's probably an area of development. I think for adult social care, it's about the level of need. So if he's independent in every other aspect, it's whether he meets the eligibility criteria. But it is about, I suppose, for me, highlighting in those areas all the local things that are going on, because he could, it could be about connecting him to a local group, befriending. So I think it's raising that profile. But local area coordination is not a social worker. So maybe we could connect them to that person, because they're in that hub of the community, and they could connect with them and help them or that person, go to groups, build the confidence. Sometimes it's just about that, isn't it? It's about building self-esteem and confidence to be able to go out and integrate yourself in the local resource. So you don't need a social worker to get the local area coordinator intervention. Maybe I can speak to you online about how we can maybe get that person connected in the community. Will that be okay? Okay.
Thank you. I think everyone else has at least touched upon some of the questions I was going to ask. Talking about co-production and the work around hoarding. Can you talk a little bit more generally about the work that you're doing with the mental health services?
So we always work with sort of ELFDA, the organisation that are sort of manage our mental health social workers, and there's lots of other things going on like the Recovery College and different sort of mental health initiatives that are available. So we work closely in partnership with our mental health colleagues, and they're very much part of the hoarding forum if those individuals are presenting as hoarding due to their mental health. So the two things I would say are very well connected, but there are, we're always working now often in partnership with them and always looking at what's available in the local community to support those individuals.
Thank you. If anyone else has... Okay, thank you very much, Catherine and Hannah. We look forward to the next update. It looks like you're going to be very busy over the next 12 months. So yeah, we'll look forward to that. Thank you.
Thank you, Chair.
Thank you very much.
Thank you. We move on to the next item, which is the draft work programme. If anyone has any ideas or any topics that they would like us to have a look at, please get in touch, and we'll see about getting those onto the work programme. We're in a continuous process at the moment of trying to sort out the timetable for the rest of the year. So the timetable you see at the back will be gradually filled in, hopefully over the next few weeks and months. And I think that's about it, unless anyone has anything else. Thank you, everyone. Sorry. Yes. Sorry, Health Watch, yes. At last week's Health and Wellbeing Board, Pat Latimer, Chief Executive of Luton Health Watch, presented their report, which we thought would be a good idea for members to have a look at before this evening's meeting. I'm not going to have a formal presentation, it's for information only, but if you do have any questions there, and I'm sure Cassie and Steph will be able to answer those. So if anyone does have any questions about that report, no, there's always the opportunity to get in touch with you outside of the meeting if you do. So yeah, thank you very much. Oh, yes, go ahead, Steph.
But if anyone's having a coffee morning, like the councillors, please invite us and then we can talk to the residents about Health Watch Luton.
Thank you, it's a great idea.
Sorry, Chair. Would it be possible for you to sort of email us your contact details on how we can arrange that?
You could send their emails to me. I will then send them, like if you send it to Pat, I mean, I can give you my Health Watch email and then you can send them to me before I leave.
Okay, yeah, thank you. Okay, I think that's finally it. So thank you, everyone. Thank you. Good night.